On behalf of the Islesboro Forum Committee, welcome to the third program of the 2021 Islesboro Forum Speaker Series. I'm Gail Jackson and the moderator of today's program. This is our 29th year of presenting distinguished speakers to the island community. Last year, because of COVID, we presented our programs live via Zoom webinar rather than in person. This year, our first 3 programs are via Zoom. Today marks the third of our Zoom-only programs. Our final 4 programs will be in person at the community center and also via Zoom. We hope to welcome as many of you as possible in person for the final 4 programs. The entire calendar of programs is listed at the website, islesboroforum.org. Before I introduce our speaker, let me encourage you to share your comments and speaker ideas for future seasons via our website. I also want to acknowledge and thank the 7 other committee members for their terrific support and ideas for this year's series. Their names are listed on the website. I also offer a shout out to our technical producer, Michael Hutcherson. Please consider making a donation to the forum. Our costs for 7 programs will be about $1,500, not counting the volunteer hours donated by the committee. We hope you will want to support the speaker series with a donation to help cover our costs. A quick reminder as to our format: once our speaker has completed his remarks, we will have time for Q&A. You should find the Q&A function on the bottom right of the Zoom webinar screen. Type in your question and hit the enter button, and the moderator will recognize you according to where you are in the queue. Now, it is my pleasure to ask Islesboro Forum Committee member John Rexwaller to introduce tonight's speaker, Dr. Myron "Mike" Cohen, on a topic that consumes all of us night and day, COVID-19. John, over to you.
Great, thank you, Gail. I'm very pleased to be able to introduce Dr. Myron "Mike" Cohen, our guest speaker this evening. Dr. Cohen is a Chicagoan, stayed close to home for his undergraduate studies at the University of Illinois at Urbana, and he completed his MD at Rush Medical College in Chicago, and then went on to do his internship and residency in Michigan. He undertook a fellowship at Yale before moving on to UNC Chapel Hill in 1980, and he's been at UNC since, where he serves as the Yeargan-Bate Distinguished Professor of Medicine, Microbiology, Immunology, and Epidemiology. And he is the director of the Institute for Global Health and Infectious Diseases at UNC. And he holds leadership positions in his field and has worked extensively around the world, particularly in Malawi and China. Dr. Cohen is renowned for his work in HIV research. And in 2005, he postulated that the antiretroviral treatment that was available might reduce transmission of HIV, and he commenced a research project with the rather unassuming title of HIV Prevention Trials Network 052 to test that hypothesis. In 2011, the results of his work were published, showing an incredible 96% reduction in transmissibility in patients using antiretroviral treatment. That's a remarkable success, which was recognized by UN-AIDS as, I quote, a game changer, and The Economist described his work as, quote, the end of AIDS. Of particular note, I think, is Dr. Cohen's belief that the work of a researcher is ongoing, especially after a successful trial, when the policy implications of research and treatment become particularly important. Vaccination policy for COVID-19 comes to mind. We welcome you, Dr. Cohen, and look forward to hearing your views on COVID, past, present, and its implications for perhaps the next pandemic, whatever that may be. Ladies and gentlemen, Dr. Mike Cohen, thank you.
Thank you, thank you. Let's see, the slides have sort of disappeared. So Michael Hutcherson, we had those open. Should I reopen them? Let's see. Let's see what happens.
Yeah, you can go ahead and screen share for us.
Is that going to work?
Perfect.
Okay, great. I'm going to use this set of slides and talk for about a half an hour. I talk pretty fast. The slides are a little bit complicated, but they serve the purpose of kind of opening up topics. So the title has already been covered. And I can tell you, so now we get into the kind of nitty gritty on this first slide. Like for any new infectious disease, the number one idea is to understand the rules that govern transmission. If you're going to, for any disease, we're going to do three things. We're going to try and prevent it, treat it, or cure it. And if you just look at the left-hand side, our highest priority with COVID when it came about, and caused by a virus, SARS-CoV-2, we call it COVID-19 because it occurred in 2019, the first cases, and we really didn't know the rules. We waste a lot of time, and we're still learning the rules. I mean, for HIV, it took us probably 15 years to understand the rules of transmission. For SARS-CoV-2, we're pretty sure that we understand the most important rules, and I'm going to summarize those. This virus wants to use receptors in the nose, and it wants to go from the nose of one person to another person. And for most people who acquire this virus in their nose, there's a replication of the virus to a very high concentration early in the infection. And then host defenses, especially antibodies, take over, and they try and lower the concentration in a race with the virus before the virus falls into your lungs and causes pneumonia. And so the dread complication of SARS-CoV-2, the negative winning lottery, is that your host defenses are insufficient to stop the development of what we call progression of disease. Now, as the virus is replicating in the nose, a very substantial number of people are asymptomatic, but still contagious. So this is a huge problem for us. With SARS-CoV-1, the SARS epidemic in 2000, everyone who was contagious was symptomatic. So we could use hospital isolation to stop that epidemic. And many of you will remember airports with temperatures taken and so on and so forth. That was very rational. That doesn't work with SARS-CoV-2 because of asymptomatic transmission. So we have lots of ongoing transmission from one person to another, most people doing well, but a few people losing this lottery and becoming very, very ill. And I'll show you a few more details in that in a second. Now, the big debates in this. So this part is written in stone. What about washing your hands endlessly, which we started out with in January of 2020? We've failed to come up with any evidence that this virus is transmitted from inanimate surfaces. Many viruses can be, best example being norovirus on a cruise ship, causing vomiting, diarrhea. And it's never a bad idea to wash your hands assiduously. No one's going to fight about that, but it's not a defense against SARS-CoV-2. Now, the third debatable area is going to be about airborne transmission in closed spaces. Most of the transmission is still going from one nose to another nose. It is possible that the air in an airplane or in a restaurant with poor ventilation can be contaminated. And we've now seen lots of studies that show us it's a good idea to reduce air contamination, but it's not the dominant problem with the transmission of SARS-CoV-2. So intimate contact of one nose to another, of respiratory droplet secretions going from one person to another, is the main enemy in the transmission of SARS-CoV-2. And as you'll see, the weapon we have is our own host defenses, or our ability to kind of inspire your host defenses to beyond where they would normally be at any moment in time. So complicated slide, but I've summarized in language. Now, this disease has not been distributed around the world, but I'll focus on the United States, equally by age or color. And what you see on the slide on the right-hand side, you see white people are blue and black people are orange, and Hispanic and Latino are gray. And you see, when you look at the ratio of deaths, there's this what we call the huge gap, a huge gap in the probability that a person of color who acquires SARS-CoV-2 is not going to do well. Now, that's a really good question for you. There's a couple of things on the slide. One is that person's not going to do well. The other thing is that most of the cases we're going to see are going to be in young people, but that it's the younger people of color who are dying more than the older white people, at least in the United States and Western Europe. Now you could say, and one should say, okay, are Blacks and Hispanics, do they have a genetic defect that renders them less likely to clear the virus from their nose? That's not the case as far as we know. We see no genetic predisposition to doing worse with this virus. We think a lot of it has to do with overall health. There are more people with underlying health conditions among people of color, weight. There's a lot of obesity in the Hispanic and Black community, and ability to access healthcare. So this disparity is almost certainly more societal and complex societal than it is biological. Now, this is probably one of the most important slides I'll show, and it may be particularly scary to a group living on an island in Maine. If you look at hospitalization and death, if we look at all other things that inform us about the progression or development of disastrous SARS-CoV-2 infection, the number one thing is age. Age, age, and age. There's other things, diabetes, hypertension, cancer. There are other things, but age, and more age. So look at the comparison group we have here. I'm not sure my pointer works. It's 18 to 29. That's our comparison group. And as age goes up, the chance of being hospitalized goes up and up, up and up and up, till by the time you're in your 7th and 8th decade, it's 8 or 9 to 13 times higher, but the death rate becomes astronomical. So once a 65 or a 75-year-old is hospitalized, they have a 220 times greater chance of dying than an 18 to 29-year-old. So age, age, and age. So not surprisingly, we focused a lot early on older people and tried to do everything we could to try and help them avoid getting this infection or treat them more aggressively should they get their infection. When I say treat aggressively, the problem is when we started 18 months ago, our only treatment was oxygen, molecular oxygen. There were no other treatments. And even now, our treatments are scant, as we'll come back to. And this is another slide, a demographic slide, again, from the United States, representing more of the United States and Western Europe. And it's trying to show you that COVID is common among young people, but they are so frequently asymptomatic and frequently do so well that gets kind of lost in the shuffle. As we vaccinated more and more older people, then the people who are hospitalizing and who are dying have been shifted to younger age groups because we've eliminated risk in a lot of older people through vaccination and through their own behavior changes we'll get to in a second. Now, so it's a really, really interesting problem, to say the least. Now, another issue here, as we face our dilemma of people refusing to get vaccinated or refusing to be treated properly, there's a lot of reasons for that. But one of the beliefs is, oh, I'm young, I'm going to do perfectly well. That's true. They probably won't be hospitalized or die. But even with asymptomatic infection, a substantial number of people with COVID, more than 50%, and probably closer to 80%, go on to chronic COVID symptoms that last at least 6 months, and some do not go away. So at my university hospital, we have about 500 people. We've treated thousands of people with COVID. We have 500 people with what's called long haul COVID or chronic COVID. So chronic complaints are very common, the most important of which are headache and fatigue and cough. So when you lose the lottery and get COVID, it's not just about surviving that COVID, it's what's going to happen to you next in your overall health. How many medical visits will you have because you acquired COVID? So there's every reason for us to be entirely focused on preventing COVID infection. So that brings me to kind of the topic we're talking about, the prevention of COVID, the treatment of COVID, and the cure of COVID. I am going to, in a very short period of time, summarize exactly where we are. The prevention has to be divided into non-pharmaceutical and pharmaceutical interventions. And non-pharmaceutical prevention is staying away from somebody with COVID and wearing a mask. Politicizing masks is probably one of the stupidest things in the history of the planet, but it's not the first time that's happened. So non-pharmaceutical interventions for prevention and biological strategies, which I'll come back to. Treatment, we are going to go eventually from epidemic COVID to endemic COVID. That's a transition we're getting ready to make. In that transition, we intend to be able to treat you for COVID early in infection to prevent progression of disease and prevent you from having chronic symptoms. We're way into this right now, as you'll see in the next few minutes. And cure is a problem. Of course, most people recover, but now we're into long haul COVID. How are we going to avoid a substantial number of people who go on the rest of their lives to complain about the acquisition of this one moment in time of a COVID infection? So the first point about prevention of COVID is it's got to be integrated, combination prevention. Dr. Corey, my collaborator on the West Coast, and I wrote this article in Science in the beginning of very early in the COVID pandemic. And we said, you have to combine pharmaceutical and non-pharmaceutical interventions. We at that time thought washing hands was more important than we think it is today. And it brings us to the great flu pandemic of 1918. And if you look at the great flu pandemic, where 50 million people died, they had one device available: masks, masks, and more masks. And even at that time, during the great flu pandemic, we saw discord about masks. We saw the anti-maskers in the 1918 flu pandemic, which would make no sense to anyone, where all your relatives are dying and society is being shut down, but it occurred. Now, talking to Gail earlier, she asked, well, or maybe it was John, well, which societies do well, which do poorly? Well, totalitarian governments do great with SARS-CoV-2 and don't suffer the same exact pandemics we do, because they have a federal, national, you will wear a mask policy. So China is the very best example. However, SARS-CoV-2 escaped from China becomes almost irrelevant to us. They've avoided massive pandemics in a population of 1.x billion because no one goes anywhere without a mask. And if you are outside without a mask, you get beaten with a stick by some old person walking down the street. I mean, there's no tolerance but for uniform behavior towards the benefit of the corpus. We see the same thing in Singapore and many other Asian countries. Asian countries that are more liberal democracies have done worse, potentially worse, and there's kind of a gradation. China and Singapore have done the best. Vietnam was doing pretty well, and now it's starting to suffer. Japan's done pretty badly. And South Korea and these other countries have used a second device. And the first device is mask. The second device is availability of aggressive surveillance and quarantining behaviors. Very difficult to do, very difficult to sustain, but a way that they approach this. And the Chinese in Wuhan in the original epidemic did something that most people aren't aware of. It wasn't just that they tested millions of people in Wuhan for SARS-CoV-2 in their nose. They also, if you had it, you didn't go home. You went to a massive auditorium filled with other people with SARS-CoV-2. So this idea of going home, which is in our culture, would not exist necessarily in some parts of the Chinese culture. Now, I'm off onto a tangent. I'm, a biologist, okay, basically. I'm off onto this more political epidemiological tangent, and I know that your particular audience would be readers, and I would strongly recommend a book called America Contagions: The Epidemics and the Laws, because what that book does is it summarizes how do we get into this trouble. Laws are passed for public health purposes to protect the body, the whole of us. But judicial interventions make those laws sometimes difficult to apply. And just to be a little bit outrageous, is that okay, Gail? Let me just be just a little outrageous. I mean, the legislature in my own state, North Carolina, passed a law that no one can be made to wear a mask. So how does that make sense? Let me take 5 people with multi-drug resistant tuberculosis, bring them to the legislature, have them cough all over the room, and then say, well, they can't be made to wear a mask. You see, we've been through this before. Tuberculosis is a disease that we've managed a lot by wearing masks. Both we wear a mask and the patient with tuberculosis wears a mask. So how do we go from recognizing the benefit of masks to making laws that no one can be made to wear a mask? It is so antithetical to public health benefit, it's shocking. So I like this book quite a bit. So we are now going to switch in this brief discussion to biological strategies for prevention. And there are going to be 3. First, active immunity. We're going to give you a shot that's going to stimulate your immune system to make antibodies and other stuff that's going to stop you from getting COVID, or if you do get COVID, stop progression of disease. I will tell you right now, to get into that there is no doubt that this shot does better than the infection. That is, if you got an infection with COVID and you think, oh, I'm immune now, like measles and mumps and rubella, that really isn't the case. So the shot is better than the natural infection, and a shot superimposed on a natural infection gives you the greatest immunity. So when we see Dr. Fauci arguing with Rand Paul, and Rand Paul is explaining why he doesn't need to take a vaccine because he's already had the infection, it belies a massive amount of data that that's not correct. Okay, it's not political. It's just like, here's the data. Here's the immune response after the shot. Now, a thing I've worked on personally quite a bit, where we made progress, is there are many people who cannot respond to a vaccine. Every day, my email is filled with people asking me, I have cancer or some other disease, and I have made no antibodies, even though I got a vaccination. What am I going to do? What we've tried to do and have done is develop passive immunity. That means we infuse you with antibodies we've already made, and that can protect you from acquisition of SARS-CoV-2. We've made a lot of progress in that, and I believe in the next 2 weeks, you'll see made available to people who can't respond to the vaccine, this idea of passive immunity being available. It hasn't been widely available to this point. The antibody is available, but the FDA has to approve this. I believe they're on the fringe of getting ready to approve this activity. And lastly, what happens when we treat somebody very early, like tuberculosis patients? We render them no longer contagious so they can go home. Like HIV patients, we treat them, we render them no longer contagious. When we treat SARS-CoV-2 or COVID-19 early, do we render people no longer infectious? That's called treatment as prevention. That's our third option for biological intervention to prevent COVID. So 3 things: active immunity, passive immunity, and treatment as prevention. Now, in order to proceed in COVID, so now it's January 2020. There are no COVIDologists. There's coronaviruses cause common colds. SARS-CoV-1, the SARS epidemic, never generated COVIDologists. There were some labs that knew how to work on coronaviruses, but no clinical translational experts. So what happened was, in the US at least, and probably worldwide, old infectious disease people were repurposed to become COVIDologists. And they were repurposed with, as on this slide. Operation Warp Speed, which is a different name now, was the US government's, under the Trump administration, investment of a very large amount of money under BARDA in order to develop vaccines with making money available. The NIH, we were all assigned to committees, and NIH and other organizations started a thing called ACTIV, ACTIV, with platforms to understand how to treat these diseases. And the ACTIV committees and the ACTIV platforms are ongoing. Myself and 3 other people were assigned to be the leaders of the COVID Prevention Network. We were told to develop the things I've already told you: vaccines, monoclonal antibodies, and treatment as prevention, working with industry to develop all 3 things as fast as humanly possible with a very large amount of dollars. So we had an enemy. This is the coronavirus. That's the spike protein that wants to get to bind a receptor in your nose. For prevention, we need to interrupt the ability of that thing to bind to a cell in your nose. Really pretty simple challenge. So vaccines were developed, and these are all the vaccines. And I just want to summarize like kind of a fundamental issue. There are 3 platforms for these vaccines. If you look down this list of vaccines, Novavax is not yet available, but that's the most traditional platform. That's a protein, a piece of protein, and what's called an adjuvant. If you've taken Shingrix, and many people on your audience would have taken Shingrix, I believe, this is no different than Shingrix. It's a protein and an adjuvant, would be believed to be very, very safe, just not yet available because it's kind of hard to make and the FDA hasn't dealt with it yet. But the clinical trials are completed. The second platform is a viral platform of what's called a non-replicating virus that gives you a piece of SARS-CoV-2 spike and hopes that you will make a lot of antibody. This is the Johnson & Johnson vaccine and the AstraZeneca vaccine. So the Johnson & Johnson vaccine is available in the United States as a single shot. But it turns out it's not as good as our third platform, and it's got its own unique side effects, the most important of which is more blood clotting. The third platform never existed. It's mRNA vaccines, which investigators have been working on for a generation, and they were working on it mostly for cancer. But when SARS-CoV-2 came along, these very smart investigators said, hey, I can make a SARS-CoV-2 vaccine in a month or 2 months using mRNA technology, which they did. Pfizer did it on their own. Moderna did it in collaboration with the government. And both of these vaccines are the mainstay of vaccination in the United States and Western Europe. These two-shot vaccines are very, very effective at either preventing infection or preventing progression of disease. Now, we are in the middle of understanding the durability of the vaccines you took. I'm willing to bet that my two moderators have taken these vaccines, but how durable are they? Do you need a booster? Why would we boost you? When would we boost you? What will we boost you with? None of this is known. We're watching a lot Pfizer, which is very secretive in Israel. And most of what we are trying to understand is what exactly is going on in Israel and exactly what is Pfizer doing. But they are boosting people in Israel, and the New York Times is our main access to what they're doing. And they argue that their vaccine, that is now the Pfizer vaccine, loses its durability at some moment in time. Now, losing durability for infection is much less important to us than losing durability for progression of disease. If you get infected and you don't progress, it really doesn't matter to us unless your infection is contagious to the next person. So we are doing a study to understand among vaccinated people who get infected, how much virus there is in the nose, and how often does it go to the next person. These are things that are logical to ask, but it takes time for us to ask these questions. Okay, so we are going to then leave active immunity and go to passive immunity, and really quickly. And the first thing we did was just convalescent plasma. We took blood from one person, gave it to another person. We took blood from somebody who had COVID, and we got their plasma, and we gave it to somebody who had new COVID and tried to cure them. Didn't work out well. So then we used modern technology, and I'm not going to go over this slide in detail. It's a great article in Science about how we can take a single cell from somebody who's recovered from COVID, take one cell, and from that cell make antibodies and make very active antibodies that could be used for passive immunity. So this would be for people either for treatment or prevention of people immediately. These are just a partial list of all the companies making these antibodies. This is not an entire list. So you see with this technology, then it's really, I would call it easy. It's very fast to make antibodies in a way we never could do before. So these are now called monoclonal antibodies. And what's the advantage? Now I'm going to do what John hates. I'm going to read the slide. Okay, so let me apologize. I'm going to slow myself down. Why do we want to use monoclonal antibodies? Because we can give you immediate protection. When we give you a vaccine, it's going to take 2 months to work. When we give you these antibodies, they're in your blood 10 minutes after we give them to you. They can be given to people who can't respond. They can block viral replication in the nose. They can tell us how to make a vaccine. And the populations we're most concerned about are nursing home populations, workplaces where a lot of people get SARS-CoV-2, and households where somebody's gone home and there's a bunch of negative people. Now, we've already completed work to prove this idea works. I'll summarize. Lilly and Regeneron were first out of the gate. Lilly turns out to be a wonderful company to work with, and so has been Regeneron. So this is what I personally have been working a lot in this one space. Most of the deaths in SARS-CoV-2 in the spring of 2020 were in people living in long-term care facilities. Massive, tragic death. And I got involved in this very early, trying to understand with the CEOs of these nursing homes what was going on. And I can tell you, every call was emotional because the staff were dying and all the patients were dying. Like, for example, in most of the nursing home chains, the residents living in those nursing homes were down to 50% because half had died. Age. So Lilly did an amazing thing. They built these vans on the right, and 7 people lived in the van. They drove around the United States like SWAT teams. And we took the antibody bamlanivimab and compared it to placebo. A nursing home would call and say, we're having an attack of COVID. The van would drive up, stay for a week, and anybody who wanted this antibody would get the antibody to try and prevent SARS-CoV-2 in people who did not already have SARS-CoV-2, or to give very early treatment. And what happened is published in JAMA. It's already published. And as you see, I was the author of this paper, so it's narcissistic, but deserves to be attended to. What you saw is when we went to a nursing home with these vans and drove up, we reduced the number of new cases compared to placebo by 82%. So it was a massively positive benefit of being infused with this antibody. And in addition, no one who got an antibody died. So we saw reduction in death and a massive benefit of the first trial of antibodies. The second trial of antibodies was with Regeneron. Here we did a very similar thing, a little bit complicated slide, sorry. Very similar thing. We went now to households. So you have SARS, you have COVID, but you got to go home. And if we could see you within 96 hours of the time you had symptomatic COVID and you're going home, we would go to your house and give antibody. And now we're going to give it subcutaneously. So it's a lot easier to give. We're going to give antibody subcutaneously. And we're going to say, if we give you this antibody, we prevent you from getting SARS-CoV-2. And by the way, if your relative already infected you, but you're not symptomatic, will we prevent you from becoming symptomatic? And the answer is basically yes. Okay. So publication is coming out this next week. This is only an abstract form. We showed that there's a reduced risk of developing infection. There's a reduced risk of becoming symptomatic. In fact, no one who got the antibody became symptomatic. Those people who actually got I should say a small number of people got symptomatic infection with markedly reduced duration of symptoms. The amount of virus in the nose for people who got antibody was greatly reduced. So these are people, either some of them were already infected but asymptomatic. Most were uninfected. They remained uninfected. And if they did become infected, it was a whole different disease. None went on to progression. We are now studying whether any of them got long COVID, but I doubt that. And as I said, this will be published this week by Dr. O'Brien in the New England Journal of Medicine. That's the next few weeks. So this is kind of what happens with COVID treatment, which is like you go from replication of virus in your nose to it falls in your lungs, causes massive inflammation, coagulopathy, and death. We have to interrupt this progression of disease. First, we have to prevent disease. If we fail to prevent disease, we need to interrupt the disease. We have to do that with either antibodies very early after infection, or we have to do it with antiviral therapy. I'll skip that. And so the FDA has already approved this combination at the top, casirivimab and imdivimab, which we call REGEN-COV. It's called REGEN-COV. It's already been approved to give to somebody who develops COVID in the first few, and you do give it in the first few days. They say 10 days. We think it should be given in the first 4 to 5 days. So we now have a massive problem of most healthcare workers don't really realize that somebody who's older who gets SARS-CoV-2 infection, they should be treated. And so we're now going to work on campaigns to make this stuff more readily available. Another agent that's available is sotrovimab, but it's not yet available for physicians. And then the combination of bamlanivimab and atazivimab, that's been removed because of the variants that you've heard so much about. We'll come back to that in a second. So our main drug for treatment of COVID right now is this combination we're going to call REGEN-COV. The variants have become a problem. These are an example of variants all over the world. You'll see that we understand pretty much why these variants emerge. Not going to read the slide. But even if variants emerge, I need to reassure you, at least for passive immunity and for vaccines, we can overwhelm variants. On the far right of the slide, this like white means that we have antibodies to which there is no resistance of any of the variants that have been reported. And all the companies making vaccines, especially mRNA vaccines, they're making new vaccines against variants. Now, the problem is, or the question is, will this virus continue to evolve forever and ever and ever? So we're always going to be chasing it, or will evolution come to an end? Will it do everything it can do? It doesn't really want to kill us. It just wants to go from one of us to another of us. And so eventually, I think it's going to run out of roads. We just don't know when it's going to run out of roads. Two last points. It's now our job then to advertise, to create demand. We have a supply. We need to create demand and have a path for somebody early in their SARS-CoV-2 infection who's over 65 or 60 years old or has something wrong with them, to have a path for them to know they have SARS-CoV-2 and treat them. It should not be throw up your hands and say, I hope I don't lose the lottery and die. It should not be that the only thing available is oxygen. So we're already advertising, or I should say Regeneron is advertising already, trying to build demand for their drug. And this is just another example of the advertising. It's not very widespread yet, but in the next year, we're going to go from epidemic to endemic. We're going to have to go to treat, this is game changing for SARS-CoV-2 or for COVID-19. Now, what's really game changing is a pill. So the best thing would be, my nose is running, I have a headache, I don't feel well. I swab my nose and I do a rapid test and it's positive. And Walgreens or whoever, CVS, we write a prescription for a pill, and that pill kills the virus in your nose, stops you from being contagious very quickly. Can we make such a pill? Yes. How long will it take us? Well, we're already doing trials. Well, here's what I was talking about. Binax now is a way to swab your own nose, and if it's positive, we believe it to be a true positive. So we already have a rapid test, and it's interesting. I play with these tests a lot, and I saw that most of the drugstores in our community are sold out. So we can see this change occurring, that they're selling these kits off the shelves very quickly. People want to know if they have COVID, and so I'm encouraged by that. So the rapid testing plus the availability of treatment is game changing. But the most important game changer is a pill. Here's a pill called Molnupiravir. Merck has the rights to this pill. It mutates the virus, and we've shown in papers we've already written that in 3 days after we give it, there's no growth of virus in the nose. So we're working very hard to show that this could be the first pill available that somebody with COVID could take to stop progression of disease. And as I said, this would really change our game very rapidly and very dramatically because, well, in many, many different ways. So I'm going to stop and leave plenty of time for questions. This last year, a great wave has washed over us. I've worked in infectious diseases for 40 years. Okay, so it's not like I'm new to this field. This is different. This is the pandemic of certainly multiple generations, where coronavirus has learned to be sufficiently transmissible to compromise almost every aspect of our society. And the progress we've made for vaccines and treatments has been nothing short of remarkable. And to read a slide, I apologize for reading a slide. What are my big conclusions from this giant wave that's washed over us? Behavior changes are required to stop the spread of SARS-CoV-2, and in the US, it's failed miserably, and we continue to fail. The political decision that our epidemic is over is leading to drastic increase in cases of SARS-CoV-2 this summer. So there's almost nowhere in the United States that is not having a surge of SARS-CoV-2 infections with the Delta variant, causing more hospitalizations and more death. Who's being hospitalized? More younger people. Why? Because we've vaccinated so many older people. We've rendered them less likely to become severely ill. We've left this middle population much more susceptible. And we've politicized this in a way, or not we, but it has been politicized in a way that's not great. mRNA vaccines are our best vaccine, unequivocally, and their new tools are incredibly novel, but there's a lot more we need to learn about them. And of course, we need to try and convince people that after this last now year, we're reasonably certain that they're safe. Well, I shouldn't say reasonably certain. We know they're safe, but all vaccines have some side effects, and so we constantly study them. Whatever side effects we see get amplified, unfortunately, in a particular way. The vaccines that we've given, these mRNA vaccines, work mostly through the generation of antibodies. Those antibodies have to go to your nose and kill the virus. So when we look at who gets hospitalized and dies, it's mostly people who themselves are slow to make antibodies. People who are vaccinated are much quicker to make these antibodies that they need in order not to progress disease. Monoclonal antibodies can easily be generated. We're really good at this now. They're already approved for treatment of early infection. They will be approved for prevention, for prophylaxis, either pre or post-exposure prophylaxis or chronic prophylaxis. Our studies in nursing homes and households show this idea works. It's just a question of creating a demand. The supply is excellent. There's no shortage of these antibodies. There's tens of millions of doses, and currently they're free because the US government bought them. So the only cost of any of this stuff, any cost would be administration costs, whether it's vaccine or monoclonal antibody. We are doing many, many studies trying to change the game and have a pill ready so that we're trying to make it as easy as possible for the patient and the healthcare provider to interrupt progression of disease. That will all happen this year, one way or the other. This next year will be different, but it's and things move very, 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 very fast. Every day, so much happens in a given day. It's like dog years. Okay, there's not a day where there's not another 10 manuscripts that are relevant to this conversation. So this is where we are, and I'm glad to answer any questions about this disease or and its management. As I said, I guess I'm a COVIDologist as much as anybody else is, having worked 18 months on COVID, but I would reaffirm to you, there are no real COVIDologists. You know, there are real orthopedic surgeons, there are real neurosurgeons, but there are no real COVIDologists. There are those of us who were repurposed to this disease. So I will stop there and answer any questions.
Dr. Cohen, thank you so much. You have so far exceeded my expectations in what you were able to convey, both authoritatively and with some degree of nuance and depth. These are characteristics that we seldom find in the typical television commentators' intervention. I would say, Dr. Sanjay Gupta, please step aside and let Dr. Cohen step in. So thank you. And also, before I open it to questions, I want to thank you again for taking the time to participate with us in this program and to speak. I know you are overwhelmed and besieged by so many people, both professionals and laypersons. So we are grateful. Now, I'm going to ask John Rexwaller to give you the first question, and then we'll go from there. Unmute yourself, John.
Just trying to find my my mouse and the mute button. Dr. Cohen, this is going to be a question I'm sure many other people will be asking in different forms. But what institutional changes would you advocate to get a better sort of institutional response, a better national response to the next pandemic? What can we do to make the next one easier to deal with?
This is for me personally, I think that the number one thing would be to federalize the response to an epidemic. This idea that we're 50 states, like 13 colonies, you know, or 50 states, is disastrous. The virus doesn't care if you live in California or Oregon. You know, it may be great for the residents of the state to elect their representatives and so on and so forth. I mean, our form of representative government is very old now, a couple of 100 years old, but the virus doesn't care. So the failure to federalize the response has left us in disastrous shape in so many ways. I mean, we wasted so much time with states competing for ventilators, competing for resources. We wasted tremendous amounts of time in distribution of vaccines. And now we see, and this is a tragedy, we see states where the vaccinated, Mississippi would be probably the best example, Alabama with 10, 20, 30% vaccination rates, with huge crises in their health care system that are really unnecessary. So a federalized response would have been the first thing. The second thing is gets back to contagions and laws. Some decision about, we've kind of lost all sense of public health law. In the generations where we grew, I worked in a tuberculosis sanitarium for 2 years. I never heard anybody debating about our laws that related to tuberculosis. How individual freedom got tied up in our responsibility to each other is beyond me. And that's represented by this mask versus maskless behavior. And it's represented by anti-vaxxing, or the notion that you have no responsibility to get vaccinated for your family or for your community. It's only about you and it's your decision. This is totally inconsistent with the history of vaccination, right? Because if we follow that down its road, why are we doing measles, mumps, and rubella? You know, why in your generation, women had terrible complications of pregnancy because of rubella. And so we made rubella vaccination mandatory at a very young age, and it's gone. And by the way, why don't we just stop? Why did we, smallpox vaccine, polio vaccine, bad ideas. Why would we do that? You know, everybody's got their own decision. If I want polio, I'm going to get polio. Let's bring back iron lungs. It makes no sense. And so, in summary, a federal response and some reconsideration of public health law, which has just been lost because we don't have a federal response. The tension's not new, but it's being played out in COVID in a way that's been very destructive to the United States and Western Europe.
Unfortunately.
Thank you for that, Dr. Cohen. I have a question from Bruce Claflin. He says the conventional thinking is that the US and many other nations have done poorly responding to COVID-19. But despite the many setbacks and poor decisions, couldn't a case be made how well we have done, certainly compared to the response to the 1918 flu? In particular, improvements in the science have made enormous progress, but the social response seems to be the major issue. Have we made as much progress as I am postulating? And if so, what can we do so that we handle the social side better next time?
That's a very wise question. Very wise question. So what actually happened is interesting. We have HIV to thank for the science of COVID. So virtually everything we've done in COVID is a response to 30 years of investment in trying to make HIV vaccines and trying to control HIV. We had a pandemic. It touched few of our lives because that pandemic was so heavily visited in sub-Saharan Africa, right? The United States always has had a problem, but 1 million cases at most a year. Plus we developed treatments. And once treatments became easy to give and 1 pill a day and people live a normal lifespan, our enthusiasm for HIV and focused on HIV waned. But the technologies, if you looked at 1918 compared to 2021, 30 years of work from maybe 1990 to 2020 gave us enormous technological power, which was applied to SARS-CoV-2. So exactly what Bruce indicated is exactly correct. 1918, there were no tools. None of this was possible. They had masks. And now, as was pointed out, the notion of integrated strategies is critical. We can do technologies, but if we make political decisions that render those technologies undeployed, ill-deployed, poorly deployed, why did we make the technologies, right? We failed to actually deploy or implement what our great successes are. And now, this gets at a whole other problem, of course. We are such a polarized country and such a polarized planet right now. We are demonstrating our weakness in moving forward, advancing our species with available technologies. As I think we were talking earlier, I said, like, the virus doesn't care about political decisions. You can declare in any state that the epidemic's over and masks are no longer necessary, but the virus doesn't care that you declared that, right? And so your particular state and your particular community may suffer grave consequences from those decisions, depending on where we are and where you're living and so on and so forth. The general belief that you hear over and over on television from the current political leadership is there's nothing better we can do right now than to vaccinate as many people as we can vaccinate, because the vaccinated person has a much better chance of not losing the lottery than the unvaccinated person. It's hard to argue that. Now, vaccines will evolve, they're imperfect, there's some side effects, but they, just empirically, as we see much less death in older people and much more death in middle-aged people, we're getting a big message, from last year. So long-winded answer, but I think that, and the word social is so big. It's such a big word, like, the behavior, we think of it as behavior changes and structural interventions necessary to implement and deploy biological solutions.
Excellent. Thank you for that. Now we've got a question on the Delta variant. It sounds as if the risks are higher than for other variants. Could you comment on that?
Yeah, so again, our technology. What's amazing is we can, in my hospital, we have so I'm again, narcissistic just at what we do. So you drive up to a tent and we swab your nose in the tent, and 3 times a day, we run a PCR that tells you whether there's any COVID in your nose. It's very accurate. It's 99% accurate of yes or no. There's some special nuances, but it's not worth talking about. If you're positive and you're at high risk, we treat you. Now, we're among the group of health providers who would give you Regen-Cove within 24 hours if you're positive and you're in a risk group, okay? The other amazing thing getting the Delta variant is for every virus that's positive at our hospital, we sequence it. So we know what we're seeing, and we see Delta replacing what's called Alpha. So Alpha is the Wuhan strain, and Delta has evolved using a lot of tools to be to have some advantages in transmissibility. Again, the virus doesn't know who you are. It wants to do 2 things. It wants to learn how to go faster to the next person, and it doesn't want us to kill it. So it's going to try and escape whatever devices we make to kill it. It'll try and escape, and it's going to try and go faster to the next person. Actually, and if it turns out to be more lethal to the next person, it's bad for the virus. It doesn't really want to make you sicker. It wants you to be coughing longer and longer and longer, making the virus anthropomorphic. So the Delta variant has evolved with all these mutations. It's more transmissible. It's filled up, and what's amazing about Delta is how fast it fills the space. It goes from like no Delta to 93% of cases are Delta within a very short period of time, out competing all the other viruses that might be available in your community. The vaccines we've made are active against, the mRNA vaccines are quite good against Delta. Our monoclonal Regen-Cove antibodies are quite good against Delta. So we have tools against Delta. And even if SARS-CoV-2 figures out, and there's also a Delta plus and a Delta plus plus. I'm really confident whatever the virus figures out, we have tools to defeat it. But as I've said, just constantly chasing the virus is not fun. We're hoping eventually it runs out of roads. It keeps going down other roads. We're hoping that Delta plus plus there's P1, Delta plus plus, and 135.1, which have slightly different other names. And as we work worldwide and talk all the time with everybody on the planet, we look at what each of these different viruses are doing. P1 is in Brazil, 135.1 was in Africa, it's been replaced by Delta, and Delta's really swept the rest of the planet.
Okay, I'm going to turn our attention to the nose. You've made the point that the virus spreads through the nose. Why isn't there more emphasis on developing a nasal spray or something that you could spray every, who knows,
Yeah,
hour?
it's a good, there are research groups trying to do this, trying to figure out ways. Remember, the antibodies we give are delivered through the small blood vessels called vasa vasorum. So when we give an antibody in your arm, very quickly it goes through your entire body and it's delivered into your nose from the backside of your nose. It's hard for us to get a really positive benefit from the front side of your nose. But having said that, there are many groups working on things to spray into the nose. It's not a bad idea. And if somebody can figure out something that's soluble that will kill SARS-CoV-2 in the nose, or something that will prevent SARS-CoV-2, that nasal spray will be, I would invest. If you're thinking of investing, if there is such a nasal spray, invest. Now, I see that, again, I see people talking about this company called Navage that ENT guys are into, of like irrigating your nose. I don't see that can be of much benefit, except to cause inflammation of your nose. And any inflammation would probably make I don't see Navage as an answer, but there may be a biological tool. It's a good question. I would buy stock if somebody actually had something that really worked in the nose.
All right. Now we have a question that deals with school-age children. How should schools handle the pandemic? If children under 12 do not have the vaccination, how should we balance the need for education with the need for student, teacher, community health?
Yeah, no, this is a terribly important question, terribly important. And and there's a lot of competing agendas. there's the teacher doesn't want to get COVID agenda. There's the idea that students are less transmissible when they get COVID. There's the idea that students won't become sick or very sick if they get COVID, which is under 12. Very true. I think there's maybe one death in the United States of a child under 12. Very little severe illness. And then the pediatricians of this country have already said we want to vaccinate young children. We want them vaccinated, but
Yes.
that's come up against some fighting about, well, why are they taking a vaccine? They're not very transmissible. They're never going to die, so maybe they don't need a vaccine. So we see this tension. Lastly, we see the mask fight. The paper was written that said children wearing masks get buildup of carbon dioxide. That paper was withdrawn, but it's quite clear that children wearing masks is not a great idea. Facial expressions are how we develop an emotional life, right?
Mhm.
So how we work this out is beyond my competence. Okay, and every day the government or the local and federal governments kind of change their minds about what should we do. School in person, no school in person. Masks, no masks. Vaccines, no vaccines. And again, we run into the no federal response problem, right? The CDC is only advisory to the United States. It has no compulsory activities, generally speaking,
Mhm.
for the most part. So this fall, I mean, September, for me personally, I don't have any children in school, but September is a time where universities are going to open again. And we had a terrible experience in September of 2020 at the University of North Carolina. We are preparing on August 17th to bring back 20,000 students. We are going to learn whether there are vaccines. 90%, we cannot have mandatory vaccines in North Carolina for a variety of reasons. Instead, we have volitional vaccination. 90+% of our students say they're vaccinated. So we will learn something, and many colleges have mandatory vaccination. So stay tuned for September and October to see what happens in colleges. That's going to be a really interesting place. I know the question was about 12-year-olds, but I care about, since I work for college, we have to move to my interest.
Right, okay. All right, I've got a very different question from Helen Elkins. How are monoclonal antibodies against COVID and variants selected? So how are they selected?
That's a really, really good question. So here's what happens. Somebody gets SARS-CoV-2 and they say, we know they have SARS-CoV-2, but we have what, millions of Americans who've had it. So we bleed these Americans and we look for Americans that have very high titers of neutralizing antibodies. Like we're looking for super duper antibodies. And in fact, we're looking for maybe antibodies that kill not just SARS-CoV-2, but SARS-CoV-1 and all SARS, pan-SARS. These are called ultra potent antibodies. Then is where technology takes over. We take their blood and we can get the B cell that made that antibody, one B cell. HIV gave us that technology. Now we got this B cell. We grow up the B cell and it starts making antibodies. We take those antibodies and we say, now we got the antibodies, let's give it to a small animal and see if it does what we think it can do. We take the antibody, we give it to a ferret or a mouse, and then we infect the mouse with SARS-CoV-2 and they never get infected. We say, whoa, this is a great antibody. Then we grow up more antibody and we give it to humans in a phase 1 trial. And we say, is this safe? And these antibodies directed against the virus are very safe. So they say, yeah, it's safe. Let's go on and prove it'll work in a clinical trial.
Mhm.
And now we think the FDA is eventually going to let us just do mix and match. They're going to get tired of clinical trials. They're going to say, you've proven you understand how this works. Make a new antibody. You don't need to test it. Just prove it's safe and you can plug it in like a plug and play, right? It's like a new app.
Mhm.
That's going to happen pretty soon.
Good. You're giving us some hope, Dr. Cohen. I've got another question from Bruce Claflin. He's indefatigable. He said, you said that mRNA scientists said they could make a vaccine in a month, but what about the issues of producing and distributing the vaccine?
Well, that's another great question. So the platform of the mRNA part is it's there, right? It's like a foundation of a house. All you need to do is decide what you want to, the framing part of the house. You just decide you're changing the framing, right? So the scientist says this the original frame we made is no longer acceptable. I'm going to make a new frame. You put it together, you got a new vaccine. Now, actually, we're getting faster. I mean, remember originally we heard, well, it'll take years to make enough mRNA to vaccinate the United States. By the time we had finished that sentence, we had enough mRNA to vaccinate the United States. What's going on now is building factories worldwide to use this technology, right? One of the hottest topics is low and middle income countries getting access to the technology. So it's, not just send us your vaccine, let us make it. The problem we have with the mRNA vaccines is they require too much cold storage. So now everyone's working on how do we get it so they're more stable, because what they are, they're in lipid nanoparticles, and they're very unstable if they're not ultra frozen. So, and then once the vials open, you have to use them quickly. All this will play itself out. The distribution problem for the United States is really not much of an issue if we federalize our response. But the distribution problem worldwide is a problem. One reason we don't want to give boosters in the United States is we'll make less mRNA vaccine available to the rest of the planet. That's one big tension about boosting. And none of us are really sure yet about the boosting. You saw in the New York Times maybe that Pfizer argues that with Delta, they're down to 36% effective after 6 months for preventing infection. They don't tell us anything about progression of disease. Whereas what we really care about is, we don't mind you getting infected, we don't like it, but if you don't get sick, we don't really hate it. We only care if you're going to get sick and get in the hospital.
Right. Now, I want to be respectful of your time. I said that we would finish. I've already taken 2 more minutes of your life than I said I would. So I want to thank you again on behalf of all of our audience and participants. This is definitely a program I'm going to listen to several times. You covered and offered so much information. And I'm going to offer you the opportunity to leave us. I have to say a few words about next week's program. You're most welcome to stay, but you're also welcome to go if that's your preference.
Thanks so much. Thanks for inviting me. I hope this was, feel free to listen to it. I'm sorry it's so technical, but we are making, let me end with optimism. We have made an unbelievable amount of progress in 18 months. And this epidemic will go from epidemic to endemic. We will have medications. This will not be forever. Okay. So I want to leave on an optimistic note.
That's a wonderful note. We thank you again very much. And I look forward to our next opportunity to engage. Thank you.
Bye.
Bye-bye. Now, for the rest of our audience, let me just say a word about what's coming up next week. On August the 1st, we will present one of the island's own treasures, Roger Heinen, a founder and co-chair with Tom Tudor of the Islesboro Economic Sustainability Corporation. Roger brings business street savvy, high-tech credentials, and great energy to bear to help the island community achieve economic sustainability. Please join us and come prepared with your own ideas on how the Islesboro Economic Sustainability Corporation can do the most for our island. He's going to be asking us for those ideas, so please work on them in advance. Thank you all for joining us, and I look forward to seeing you next week. Good night.